Welcome to Sight and Sound Bites, the bi-weekly webinar series of the Eye and Ear Foundation. The Eye and Ear Foundation is the fundraising entity for the Departments of Ophthalmology and Otolaryngology at the University of Pittsburgh School of Medicine. We raise money to help people improve the way they see, hear, and live. Today's topic is a great one, but first, a few housekeeping tips. Chat is disabled. Please put questions in the Q&A. We will answer those at the end. And please refrain, if at all possible, from personal medical questions. If we do receive any of those, we will send that directly to the team and answer separately. So today is a webinar from the Department of Ophthalmology, and it's next generation therapies to slow or halt age-related macular degeneration vision loss. We have two wonderful speakers with us. Unfortunately, Dr. Martel, who is going to join us, is not able to do so, but we do have his slides. We have John D. Ash, PhD, Executive Vice Chair of Research for the Department of Ophthalmology. He holds the prestigious E. Ronald Salvitti, MD, Endowed Professorship and Chair in Ophthalmology. We also have Dr. J. Chhablani, MD, Vice Chair of Clinical Trials, Director, Clinical Research at UPMC Vision Institute, and Professor of Ophthalmology. And we are going to start with J. Chhablani. Thank you.
Thanks, Heather. Thank you so much for the introduction. We really love these webinars because I feel that, we really take our research, what's going on in the UPMC Vision Institute to our patients who are very interested to understand what's up and coming in our institute. So let me start with my presentation. Before I really jump on to macular degeneration, I would really want our patients, our audience to understand that macular degeneration affects the centralmost part of the retina, which is called macula. And if you look at this fundus photograph or the retinal image from a patient with macular degeneration, you will see that the yellow circle, which is called macula, has these deposits, which are also called drusen, which is one of the signs of age-related macular degeneration. And before we really get into AMD, it is important to understand that retina, though we call it as retina is one of the layers of the eye, but retina itself has 10 layers, and this is the cellular distribution. You don't need to really get into the details of these cellular divisions, but actually try to understand that retina is pretty much the extension of the brain, which has all types of important cellular architecture in starting with the ganglion cell, which is very much similar to the brain cells, to the photoreceptor, which is the cells which actually helps us to see, to have some vision. So we won't be going into the details of individual layers, but just to give you the impression that, we are really working with a very important cellular structure where individual cells, they are playing a very important role, and that's how different therapies are being targeted for these cellular structures. So when we talk about AMD, AMD or age-related macular degeneration is divided into two types. So one is the dry macular degeneration, which is on the left, which where the signs are drusen, which is what I was showing you in the last image as well. And this dry macular degeneration can extend from drusen to atrophy, which is shown on the right side. So drusen are very much early and intermediate stage of the dry AMD, and atrophy is a very advanced stage of macular degeneration. And many of the times when this dry age-related macular degeneration converts into wet macular degeneration, the patient can have a blood in the eye, which is something similar here. It is shown in the picture where the patient with macular degeneration presented with a sudden vision loss with this large subretinal bleeding, and which led to vision loss. So what is wet macular degeneration? When there is a formation of abnormal blood vessels under the retina, which starts leaking, bleeding, and the patient will have a significant vision loss. The difference between the dry and the wet macular degeneration is that the dry macular degeneration is a slowly progressing disease starting with drusen, leading to atrophy, leading to vision loss. But wet macular degeneration, these patients most of the time have an acute change when the dry disease converts into wet. They will come to us with a recent vision loss because of the swelling, because of the bleeding. And that's why we need to offer the treatment immediately. How does the patient know that there is a change in vision? So we usually ask our dry macular degeneration patients to do this Amsler's grid, this square which you are seeing. I'm sure that many of you have seen this chart called Amsler's grid, where you can see that there is a central dot. There are lines which are vertical and horizontal. Everything looks straight. When you cover your one eye and keep looking at the center of this chart, you will see rest of the lines are looking very much straight. Nothing is missing in this. But when the patient has some disease involving the central area that is macula, they will have some form of distortion, some form of change in these lines. And this is how our patients will report to us that, oh, I have a recent change on my Amsler's grid. And that is where we need to start looking at any of the macular diseases. And that's why we call this as home Amsler's grid monitoring. So patients really don't need any fancy instrument, but actually just looking at the grid one eye at a time will let them know if there is any change in their macular area. So what are the dry AMD management strategies? So as I was mentioning that, dry macular degeneration can be as early as like very few drusen to an atrophy where the retina is thinned out, which we also call as geographic atrophy. So dry AMD extends from early to advanced disease. So unfortunately, there is no treatment to stop the progression of the disease at this stage for early, or there is no way we are able to really um, stop worsening of the disease. The only treatment option now we have available is for geographic atrophy, where the disease is already advanced. So we still don't have any treatment, certain definitive treatment to prevent from going to early to advanced. But there were a couple of trials done almost 2, 3 decades ago, which brought these multivitamin treatment for early dry macular degeneration, which many of you are aware, which is also called ARIDS medication. These are eye vitamins, which showed the benefit of preventing the progression from intermediate to advanced macular degeneration. So we definitely prescribe these vitamins. Along with this, we also request for antioxidants, and now there is a recent data supporting the role of Mediterranean diet preventing slowing down the progression of macular degeneration. And yes, the smoking has a very strong association with macular degeneration. So we would request our patients to stop smoking, UV protection. The most important thing is to actually identify this disease very early. That's why I think home surveillance, which I just showed with home Amsler's grid monitoring, is very important factor. And we also do retinal imaging. Nowadays, we have a lot of tools coming up for screening for macular degeneration. Retinal imaging plays a very important role. And if you are seeing your optometrist or ophthalmologist once a year, they would definitely be looking for any signs of macular degeneration. So as you understand that the early dry macular degeneration has mostly a supportive treatment where we don't have any definitive way to stop the disease. But what is more important is to talk about the advanced disease, which is where the wet macular degeneration comes in the picture, as well as advanced atrophic or geographic atrophy. So I'm sure that many of you are aware that when the eye converts from dry to wet, we start them on injections, which are the anti-VEGF therapy, and they have been there for more than now 2 decades, and they have shown significant benefit for our patients, not only to stop the progression, but actually to improve the vision as well. However, these injections need to be done on a regular basis. We have to keep monitoring these patients, just because, even when you stop the injections, the disease can come back. While talking about advanced atrophic or geographic atrophy, we recently have two injections which got approved, which are anti-complement therapy. And I'm not sure if you have heard these names, from your doctor's Syfovre or Izervay, which are the monthly injections, which are the first approved treatment for geographic atrophy, which they claim to be slowing down progression with monthly injections. However, this is like the first treatment option, so we are definitely using these treatment available options, but I'm sure that there is so much going on, which I'll be showing you for this disease. So before we really go into the future, we also want to discuss about the low vision aids or therapies, because many of these patients, very unfortunately, we are not able to treat them. We are not able to prevent the progression. So we end up offering them low vision aids, special lenses, electronic symbols, and there are surgeries which we don't do much here, implantable telescope, because the results aren't so great. But in Europe, they do this surgery very often. And as well as we are able to offer them digital aids for their routine activities as well as occupational therapy. So these are like kind of more towards the end when, we are not able to improve their vision, then we don't give up. We actually offer them options which will help them to perform their routine activities. So let's talk about John. Do you have any comments, questions, or something to talk about before we get into the research?
No, I'm good actually. We'll talk a little bit more about those new therapies.
Excellent. So let's talk about what is going on in age-related macular degeneration or AMD research, which is where our UPMC Vision Institute is leading the way in this part of the country. We have pharmacologic therapies, we have regenerative medicines, and we also have advanced technology, which is done in very few centers, which I'll be talking very briefly. So when we really talk about pharmacologic therapies, we have newer drug targets. We used to do injections every month, but now the newer drugs are letting us give treatment free or treatment break or injection break for our patients for almost 3 to 4 months. We have now new options of sustained drug release systems, which is again we are offering in our institute depending upon which type of treatment the patient is undergoing. There are few therapies for neuroprotection as well as combination therapies. When we really talk about regenerative medicine, this therapy is still in the trial stage, or I would say on the still on the development side, where we have stem cell therapies as well as cell-based therapies. There is a lot of research going on these two kind of therapies at UPMC Vision Institute, and we are hoping that we will be able to contribute in this field as well. Then we have advanced technologies such as artificial retina or optogenetics. Again, UPMC Vision Institute is very much leading the way in this artificial retina and optogenetics. Dr. Sahil has been primarily involved in optogenetics component. And then we have gene therapy options as well. And we are conducting multiple trials on gene therapy for age-related macular degeneration. And we are seeing very promising results. However, as you all can understand that, these therapies are still in evolving phase. We still have to follow up these patients for a long, long time, and then only the FDA is going to approve these therapies. But this is a very exciting time for our patients that, we have certain treatment options coming up, such as gene therapy, where, we can actually stop the progression, stop the recurrence of the disease. And then now we have a photobiomodulation option where, this is the therapy which was recently approved by FDA, which is now being available in multiple sites. We are not yet offering to our patients because we still want to get more data, understand more real life benefits of these treatment options. But this is something which has been there for quite some time, particularly in Europe, but now FDA has approved, so we will learn about this very soon in coming years. I just wanted to bring up a few things about gene therapy because we are conducting multiple trials, and I'm sure that our audience are aware about the gene therapy, which primarily started with inherited retinal diseases, but now we have gene therapy options for both dry as well as wet macular degeneration. the whole idea here is to introduce the desired gene, which can actually modify the protein, which will help us to get the treatment benefits. I don't want to go through all the list, but I just wanted to show that we have multiple gene therapies which are coming up for macular degeneration, both for dry and wet. So I'm really excited that, in next couple of years, we will be able to offer these gene therapy treatment options for our patients. I will switch gear to primarily to what Dr. Martel has been primarily working on, which is photovoltaic restoration of central vision for atrophic AMD, which is where, UPMC Vision Institute was one of the early sites for something called Prima implant, which is actually an implant placed under the retina, which where patient is wearing the glasses and the images are being captured, and it is being processed through this implant. So we have already included a couple of patients in this trial, and the results are looking very promising. So I'm really hoping that we will be able to offer such treatment options for our advanced atrophic macular degeneration patients where no other treatment options are actually effective. This is one of the pictures from one of our patients where you can see the implant is sitting right under the retina, and you can see that it is in our opinion, there were no side effects, and the patient has some improvement, but this is something which we will be looking into upcoming days. But before I end, I would also like to emphasize on something very important, that in this whole presentation of last 10, 12 minutes, you understood that, we really need to identify the patients with macular degeneration way early. So before they have disease already progressed, cause the vision loss, it is very difficult to really bring back the vision what they have lost. So our goal is to actually identify these patients way early before they lose the vision. So our group, which is primarily focused on artificial intelligence, has been working on developing tools, AI-based tools, which will help us to identify the disease way early. And our group has spun out a commercial entity, and we are really targeting to push forward this technology to the rural areas, to our optometrist, where we will be able, where the patient will be encountering their doctor for the first time. So can we actually identify the disease way early? So I'll just play this video to just give you the clue what we are aiming for in coming years. And I can tell you it is not far. We are almost there.
Welcome to Netrimind, an AI-based solution for age-related macular degeneration management. You can log in or sign up here. This is the dashboard where you can navigate between different tabs, see patient stats, add a new patient, or filter patients. You can also see patient details along with diagnosis. Let's look at adding a new patient. Here you can add basic information about the patient, as well as any risk factors. Let's look at an existing patient. Here you can quickly see the longitudinal and face images of the patient, along with drusen area, chance of conversion to wet AMD in next 6 months, as well as risk of foveal involvement. You can run a new analysis on the selected OCT volume of the patient. Here, clinician will first select the foveal center. Here, clinicians can see 2D in face and the drusen segmentation by the AI model. Here you can see the current drusen or GA area, along with forecast of the progression predicted by the AI model, as well as chance of conversion to wet AMD and GA. Clinicians can also see patients' notes here. Finally, a report can be generated with detailed analysis, showing how the disease may progress based on the AI model. Here you can see forecast of the drusen area predicted by the AI model for the next 3 years. Thanks for watching. To know more about us, please visit us at netromindinnovations.com.
Thank you so much. That's all from my side.
So actually, thank you very much, Heather, and I'm happy to follow Jay on what he's presenting, and particularly in this particular model, because it's really is going to help us identify which patients we need to treat more aggressively or more active in their therapy. I am been at the University of Pittsburgh for about 2.5 years now, and I'd say it's probably the most active and vibrant research center in ophthalmology that I've ever worked. So it's a privilege to work here with such great colleagues, including Dr. Chhablani. So just to refocus a little bit, what Jay was saying about the different phases of AMD, you have a normal eye, it's a fundus exam, an ophthalmologist, and you have an early AMD, which most of us probably can't even tell that's a patient with AMD. There might be very, very small drusen. You might need another test called optical coherence tomography to see it. But just a very, very early, the patient won't even know they have these. They'll have normal vision. They may not even have any change in vision. And it would take a visit to an optometrist or an ophthalmologist to tell them there's something to worry about. And then later, this is an intermediate phase of AMD where the drusen might get larger, some might be soft or hard, the different shapes of it, but there'll be more of it and they'll be larger. Still, there'll be very well preserved vision in these patients. And then the patients that we're talking about advanced AMD, this is the geographic atrophy or the wet AMD, those patients are the ones that typically come in complaining of vision loss already. And that's what Dr. Chhablani was mentioning. They'll have some distortions in their amphilar grid and, hey, I've got a problem. Those patients will have either loss of the RPE or they'll have these blood vessels and leaking and growing under the retina, and you'll have swelling and inflammation taking place. And those, unfortunately, this is where most of the blindness occurs in these late stages of disease. A lot of the vision loss occurs in these patients. And that's why this has been the main focus for therapy and intervention, because these early and intermediate patients still have very useful vision. And maybe we didn't need to treat them so aggressively, we thought. And we should really focus on these late patients and try to stop that. So most of the new drugs and new therapies are really targeting those patients that we have that are available. And as Dr. Chhablani mentioned, we have very, very limited treatment options to actually prevent the progression from early to intermediate and then to late disease. And this really is an intense area of research for new therapy development, because really, if we can halt or block or stop this or slow this progression, this really is a progressive disease. You don't have to progress very fast. You can progress slowly. But if we can really make everybody progress slowly, because some patients don't, they progress rapidly. We make everybody progress slowly, then it's possible for patients to actually outlive the blindness. They will not go blind from AMD. And really, that's kind of an area what we need to do. And much of this is going to rely on these early prediction and detection and predictive tools that Dr. Chhablani is working on. And these are going to be an important, I think, part of our tool chest to really identify these patients and really keep track of them clearly to identify who needs intensive therapy. They're also going to be useful for us in future clinical trials, so that when we are developing therapies to target early and intermediate AMD, we can actually then use his tools to track to determine whether or not we're developing effective therapies. One of the reasons we don't have therapies for these early intermediate stages is because the clinical trials to test new drugs are horrendous. It takes a lot of patients and many, many years to really figure out whether or not your therapy did anything at all to help the patient. And so we really need better tools to develop clinical trials. And that's what I'm excited to work with Dr. Chhablani over. Just again, this is part of the retina that we're talking about. This is the tissue in the back of your eye. It's part of the central nervous system, part of our brain. These are the cells we need to think about. Not going to teach you a lesson here, but just the names, just so if I say them accidentally later, you'll know. There are photoreceptors. There are cells that actually capture light and send the signal to our brain. And then these retinal pigmented epithelia, RPE, which sit underneath them, and there's very supportive cells that actually are needed to maintain those light sensitive neurons. And then there's also a choroid underneath us where the blood vessels, the inflammation, and some other part of the disease takes place. But really, I want to look at questions we wanted to ask. How do we keep these light sensitive neurons alive, and how do we keep the RP alive and keep them functional and healthy? Because really, this is where we need to target therapies, is really to target those cells and prevent those cells from becoming stressed and prevent them from becoming damaged. So to do that, we have to understand the risk factors. Genetics is a pretty strong risk factor. They're basically mutations in 32 genes that are strongly associated with disease, some stronger than others. About 50% of the patients with AMD will have mutations in 2 different chromosomes. So we can do risk scores, genetic risk scores to determine risk, but it doesn't really predict who's going to progress or who's going to actually have serious disease. So genetics is part of it, but not the full story. Age is also part of it. So things that happen to us as we get older, cells become less resilient, they less changes in metabolism. That's also going to play a role. And then this, Jay mentioned this behavior, such as smoking and probably a lot of alcohol, over use of alcohol, obesity, and high-fat diets, part of that behavior for that. And there's some exposure as well, so environmental toxins, but also drugs that we might take could exacerbate that, as well as a microbiome, basically the flora that live in our gut that help us with digestion, that can also accelerate or prevent progression of AMD. And a lot of clinical trials exploring that at the moment. But really, once we look at those risk factors, we talk about how they affect the cells. There's one of the biggest components is changes in metabolism. That leads to loss of cell function, that leads to increased, we call it oxidative damage, oxidative stress, leads to damage to the DNA in the cells, the photoreceptors or the pigmented epithelium, leads to local increased inflammation, cell death, and then that's a cycle. So once one cell dies, then it's more likely that the neighbor cells start dying. So you can get really enlargement or progression of that affected area. And so obviously then the treatment options we do look for are things that can restore metabolism, things that can maintain cellular function, can decrease that stress, oxidative stress and DNA damage, can things target inflammation. And of course, when we do that, will lead to prevention of loss of cells and maintain healthy vision. So really our target, I think one of the things we've looked at early on is a target for restoring metabolism and maintaining function, but then things that also might reduce these sort of inflammatory events that take place. So those are kind of the new areas where we think we can actually develop things that would prevent the progression for that early and intermediate AMD into late AMD. And this was some work from a graduate student who worked in my lab, Lei Zhu, and she was testing some drugs, small molecules. These were FDA-approved drugs taken for other purposes. This particular one is Metformin. And when treated, and we used mouse models for retinal damage, they had an inherited mutation that caused the death of the photoreceptors. So if you look at a normal, that's labeled ONL, that's where the photoreceptors are in this measure. And then when mice that have this model, those photoreceptors die very quickly. But if we treated them with metformin, the photoreceptors were surviving with that. So this is a drug that actually targets metabolism. And of course, it doesn't make them completely resistant throughout their life. They actually really make them resistant to death. And it preserves cones quite well. And if we do measure function of vision, these animals can actually see. So it really is, we can target drugs that will target metabolism that can give the retina a much increased resilience and allows them to resist the stress that's causing the progression for AMD. And also, it's not just the photoreceptors, it could also be the retinal pigmented epithelium, the cells underneath. Just showing here in the slide is the green cells. If you see a lot of green dots, those are healthy RPE in there. We treat them with a chemical, sodium iodate. It's very toxic to RPE cells. They died. You can see they're missing a lot of the green dots. And if we treat them with metformin, and before we treat them with sodium iodate, we can actually prevent those green dots to prevent the cells from dying. So this drug was able to increase their resilience and prevent them from undergoing death from that stress. So we look at that as a way that we can we treat patients with that may actually benefit them and really slow down the progression of degeneration. In fact, there's some clinical trials ongoing now with metformin for that very purpose. The other thing we looked at is what goes on with these stress responses or injury responses that are taking place. And if we have damage to photoreceptors RPE, then that's going to cause an inflammatory event that leads to activation of immune cells, and then they release these proteins that would stimulate other damages and other responses in the cell. But some of those responses are actually beneficial. One of them we found is an induced expression of a protein called leukemia inhibitory factor. or LIF, just use that since that's easier to say. So LIF actually is a very potent activator of cell stress responses, and it's a very powerful way to induce resilience or increase resistance to damage. And when we inject in more LIF, we actually can even protect the photoreceptors in the RPE from those same degenerative models I showed you what we did with metformin. In fact, it's even more effective at protecting the metformin. However, when you're doing this, you're injecting a protein that doesn't last very long. You'd need weekly injections, which is really not a very good therapy for multiple years of treatment for chronic disease. So we're looking at ways to improve that. So another grad student was worked with me in the past, a former grad student, was developing this into a gene therapy, where we package this protein, we put it into an AAV vector, and we could actually deliver it into the eye, and then we could deliver the protein that would then protect the photoreceptors. And what Clayton went on to actually make this a regulated gene therapy, so we could control how much of that protein was made, which I don't need to go into details of that. But what we tested in these same animal models, mouse models, of looking at protecting the photoreceptors, and what he found was just like with the metformin, when we put the virus in, we could have long-term protection of rods and cones, and we did vision tests, and the mice actually could see quite well. I don't need to go through some of the assays, but just to know that these data that I'm showing on the slide are telling us that these new therapies, both the drug as well as this gene therapy, are able to increase the resistance of the rods and the cones and the retinal pigment epithelium to otherwise insult the insults that would otherwise cause them to die. So it really is increasing their resistance to degeneration. And so in short summary, just saying that, we had, and previously this landscape, we had all of these therapies treating vision loss in late AMD, and now my lab, as well as other labs here in the University of Pittsburgh and UPMC Vision Institute, we are developing therapies that would allow us to slow down the progression of early and intermediate AMD so that we may never reach these late stage diseases. This, we think, would give ophthalmologists new tools that would actually help their patients. And if Dr. Chhablani comes up with these great predictive models to know who might need these therapies, then these would be the patients that we would propose would need this additional preventative therapy to prevent that progression. If somebody's never going to progress, we don't really need to treat them. But if we have patients we know are going to progress, it's much better to rescue and save their vision before they lose it than try to restore it after the vision is lost. So this is our landscape at the moment in the department, and this is kind of just the stuff in my lab, but there are other groups here working on other drugs as well, and other gene therapies to target these early stages of disease. And just I don't do this work myself. Actually, it takes a team, and I just want to acknowledge the very generous support of the donors and to the Eye and Ear Foundation and the Eye and Ear Foundation itself, because they really provide a great resource and support the work that we do here to drive these new therapies. And so thank you for your time.
Thank you so much. We have a robust amount of questions, but I wanted to start with 2 questions of my own. So when you're developing new therapies, how do you interact with each other, different research, different clinical aspects? How do you come together to partner on these things, this type of research?
So I can start off with that. So, when I look at what I do in the lab, there are many things I can do, but I really need to stay focused on the disease and what the patients are experiencing and what might actually benefit the patient. And to do that, I need to talk to patients, but more importantly, I need to talk to the clinicians to understand, when you see your patients, where do we have an unmet need, right? What do we need to develop to actually benefit the patient the most? And these kinds of discussions actually lead to advances for what we're doing. But it also, I talked to Dr. Chhablani, I get a lot of value of what he's doing and develop these predictive models, because what that is going to do is to allow me to actually test my therapies in a clinical trial, because otherwise it would be very expensive and very difficult to test these early stage disease therapies. So really, we have meetings, not as regular as we should, but we actually have important discussions. And I'm reading publications from each other, but we also, we just bump into each other and, hey, I've got this idea. What do you think? And sometimes, that is it's good that we work in the same department, the same building. And, this is really where this happens. So.
And that's part of why this building was built the way it was, is for collaboration, so that everyone could be together and run into each other, which is
True.
good. So the second question I have, and it's actually going to link to one of our attendees' questions. So you're talking about metformin. And metformin, there've been lots of discussions about the protective powers of metformin. I know several years ago at the University of Pittsburgh's Winter Academy, they talked about how metformin, taking it really helps the aging process. So you're talking about it here, but we had an attendee ask a question, which is, if you are a diabetic and you're having eye issues, should you ask your doctor to prescribe metformin first line? And Dr. Ash, your biography, you are a renowned person with research relative to metformin. So if you could answer that.
So actually, Jay and I have independently done similar studies. We actually looked at patients that were in two different studies. We looked at patients that were taking metformin and did ask the question, were they less likely to develop AMD? And both studies showed that there is a reduced risk for developing AMD if you're taking metformin. That's been replicated in many studies now. So, but those are very difficult ways to answer the question. They're not always, they generate hypotheses.
Right.
They don't really test them, right? I think some clinical trials are needed to do that, but at the moment they're ongoing. There are people doing those, not here, but the other institutions.
Mhm.
But we'll know some answer. I actually think metformin is, even though I used it, I think it's a terrible drug for this purpose. It's a water soluble drug. It doesn't last in your body very long, and to get it to be effective, you're going to have to take it more frequently. So I think what we need to do is better drug screens to actually find what it does is very beneficial and very helpful, but we need a better way to that pathway. We need a better drug. And so we're actively working on developing newer drugs that can target the same pathway and to be just as effective. But right now, if you're a diabetic and you're metformin, type 2 diabetic in particular, metformin is generally a good first line drug. And I think that's what.
And it is PCPs, that is one of the first ones they usually offer.
Correct, yeah.
Dr. Chhablani, any idea on that as the clinician on this call?
No, I think as John was mentioning that, there are a lot of studies, retrospective as well as big data studies. They all have been showing a good association or beneficial association of metformin on AMD. However, we just have to understand that macular degeneration is a multifactorial disease. So which patients are going to respond well to metformin or which patients it is going to be beneficial. And I think that is where I think identifying the right patient is one of the biggest needs. We have multiple associations, but with many things, but which one works stronger in which patient, that's something which we should really work on.
Absolutely. So let's get into some of these questions. When will AI be available to my MD?
I wish it was yesterday,
Yeah.
but I would say that at least some of our algorithms are getting very close to being available, at least in the research phase in the clinics. Bringing for clinical decisions, we have to go through the FDA approval. And I just means I know that this question is asked by so many patients every time in the clinic. But I would say that, I'm very excited that we are getting closer to this. However, again, we have to understand that these AI models will keep developing, keep improving. So we are aiming to bring it in the research stage in the clinic maybe next year. but whether we will be able to use it for the clinical decision making, that might take a little longer time. However, we are definitely focusing towards bringing it in next 2 to 3 years.
Wonderful.
Yes.
So what is the molecular basis for AMD?
I'm
I
glad
wish-
I don't have to answer this.
I wish we knew. Actually, there are genetic risk factors.
Mhm.
Probably the biggest part of that are going to be inflammatory system, the immune system. But there are but they're not predictive. You could have a genetic mutation, but not have it gives you risk, but
Mhm.
you don't actually develop AMD. So it's not predictive. So we don't do genetic testing or screening for that now. Age is a big risk factor. So the changes with age matters, right? So
Mhm.
that can accumulate damage that would lead to cells losing function and then dying. That is part of the risk factor disease. So that's my answer. We would love to be. We're really trying hard to figure out what is the cause of this disease. Jay?
I know nothing more than you, John, on this. But I think that, like we were discussing, that there are so many things which are playing role in as if in regards to cause the disease or progression, conversion, complications. So I see so much variability in the patients that it is very, very hard to really pinpoint that this is the cause.
Mhm.
But yeah, we have several therapies, we have several approaches coming up. So, many times we try something, it doesn't work, we switch. So these are the clinical limitations at our end.
Thank you. So we've gotten to, people are really fascinated by this talk because we have two different questions. One is, can this webinar be sent out to everyone, and where can it be found? So the Eye and Ear Foundation will send out this webinar to everyone on our mailing list. If you join this webinar, that means you're on this mailing list. It'll be sent out in about a week, maybe a little earlier. And then it'll also be found on the Eye and Ear Foundation website, which is www.eyeandear.org, along with all of our former webinars. So it'll be out there. Okay, so I see ads on TV about GA. What is it?
The GA is the geographic atrophy. It stands for geographic atrophy, which is the advanced form of dry macular degeneration. If you guys saw my presentation, I believe the second or third slide had a picture of GA where, the retina starts getting thin as the macular degeneration progresses. But unfortunately, we don't have any treatment to prevent from early disease to lead to GA. But
Mhm.
luckily, we have now 2 treatment options available to slow down the progression of the GA. If it is not affecting your central area, if your vision is still good, you can still have GA coming from the periphery and involve the center. So these treatment options are to slow down this progression. They are not I would say, not the best in the lot, but these are the only options which we have. So I do have many of my GA patients who are undergoing the treatment. We are seeing some benefits. Again, the patient identification and which treatment will work for which patient, that is something which we will learn with time.
Thank you. How important is a family history of AMD for screening?
John?
Well, there are genetic risks that are inherited. So your parents, if you inherit your genes from your parents and both of them had AMD, then you might be concerned about the genetics, but nobody does genetic testing for that
Mhm.
specifically. It's not a clinical diagnostic test yet. But so yeah, I think at that point it is important to actually increase the surveillance and check. You don't have to be really worried about it. You'll basically just go see it, get an annual eye exam or a couple of years initially when you're younger, but it don't be super worried about it, but just go and check it out every now and then. And even you go to an optometrist, they do screens now. So
Well, and that's the next question. Is AMD genetic? Should I get a genetic test if my parents had AMD? So when you're getting your annual eye exam, letting the optometrist or ophthalmologist know is very important.
yes, yeah.
Okay. Do people with dry AMD ever completely lose vision?
I'll take this one. So macular degeneration, luckily, it just affects the central part of the retina, which is the most important part, which is the acuity we use for most of our activities, especially reading, especially any near work. So the macular degeneration is certainly going to affect your reading abilities. However, when we call blindness, that means that you cannot see anything. But with macular degeneration,
Mhm.
you can have a scar in the center, but you will still have the peripheral vision, which will help you to at least get around with your everyday life. Again, it depends that how significant it is, what other disabilities these patients have, that will also influence.
Thank you. Can you provide more information on the Prima glasses and who would benefit from them?
So, Prima is very much for the advanced atrophic macular degeneration, where we do not have any other treatment option available. So, there are 7 to 8 clinical trial sites in the world where they are doing this therapy, and we are one of them. Dr. Martel and Dr. Sahel are leading these trial. We still don't have I should say, the future direction, which when are we going to get the FDA approval? But the clinical trial is going on, and I can say that the results are promising. So, as soon as we are getting closer to the FDA, we have the database which we are building up for our patients, and we will definitely be reaching out to you. Or if you are seeing your retina specialist, you can certainly bring this up for the discussion.
Wonderful.
And just to clarify, it's not just a pair of glasses. It's actually a surgical implantation of a chip underneath the retina that works with the glasses.
Yeah.
Really an amazing new technology that it really can be activated by this light that you can put in through these glasses. It's a light emitter, and then that signals a signal to the retina, which then communicates to the brain. It really is an important device, but it really for patients who really have lost the central vision. The vision is severely impacted already. Those are the patients that would benefit from that.
Thank you.
Thanks.
So, along the subject of glasses, what should we look for in sunglasses to help protect?
Uh, we believe that the UV radiation does has some association with AMD. So UV radiation protective glasses, yellow color, those are some of the glasses which we advise. But again, it's not necessary that your macular degeneration will not happen or will not progress, but it is one of the factors which has been associated. So we do advise this to our patients.
And good sunglasses are vital to anyone who's going to be out in a sunny area for long periods of time or driving. Just
Will
very
help.
helpful.
Yes.
How often does dry MD convert to wet MD?
Very difficult to answer, but it varies between patient to patient. On an average, what our research has shown that between two eyes, we see in the range of 8 to 9 months to 1.5 to 2 years. But because you have wet macular degeneration in one eye and you are seeing your doctor on a regular basis while they are also scanning your healthy eye or a good eye, and if there are any early signs, they will pick up. So that's why that identification or detection of wet conversion in your other eye is usually much sooner.
Got it. Well, gentlemen, thank you. Dr. Ash, Dr. Chhablani, thank you so much. This was we did miss having Dr. Martel with us. And so thank you for presenting his slides. This was a wonderful hour with lots of great information. Like I said before, we will get the tape of this sent out to everyone who'd registered. And please look for our other past webinars on the Eye and Ear Foundation website. We'll be back in 2 weeks with another webinar, but I want to thank all of you and have a good Friday. Thank you.